deliver this talk on Dr. Rosenfield's behalf, so I want to thank Dr. Banerjee and Dr. Shishpur for inviting me to the meeting again this year. I am, however, an active member of the BEST-CLI Publications Committee and a bit of a BEST-CLI groupie, so I give that as my disclosures. Two brief goals for the next few minutes. First, just give a brief overview about the trial in case you've been on another planet for the last several years and you haven't heard about it. And then talk a little bit about what we've already learned. I'm not much of a forecaster, so me telling you what the trial is going to show, I think, is a little bit out of my scope. There's that saying that Winston Churchill and then a different philosopher said beforehand, that those who don't know history are doomed to repeat it. Does anybody recognize this paper? This is New England Journal, 1991. It's entitled Use of Angioplasty, Bypass Surgery, and Amputation in the Management of Peripheral Arterial Disease. Raise your hand if you read this paper. I read this paper when I was a fellow back in 1999, or an intern, actually. And at that time, this is a study of Medicare claims data in Maryland. They found that this paper sort of single-handedly held off the endovascular CLI revolution for about a decade, because what they found when they looked at claims data in Maryland was that the use of percutaneous interventions was associated with an increase in amputation rates. This was completely confounded, wasn't risk adjusted, and essentially was just observational evidence that really probably wasn't really well understood at the time. Probably not surprisingly, just given the lack of detail that was available clinically. So this data really actually held off progress, I would argue, for a while, because its conclusions were so dramatic. The first line of this in the conclusions paragraph was the use of endovascular interventions was associated with an increase in amputation rates. We know from data a decade later that exactly the opposite was probably true. But this was disseminated in our most, sort of prestigious journals and really held off, innovation, I think. So I think this paper showed that, well done, high quality evidence in CLI is really absolutely necessary to guide our decisions, because this is in our best journal, and yet it was probably not the right direction. So RCTs, represent the top of the pyramid in terms of evidence quality. They eliminate confounding, they minimize treatment and selection bias, and really are probably the best form of scientific evidence. The trouble is they're time intensive, they're expensive, and people always argue whether or not the data derived from them is generalizable. Are there randomized trials in the treatment of patients with CLI? As we all know, compared to other disease states like coronary artery disease or cerebrovascular disease, there's a pittance of data. Shown on the left-hand side of the slide are the number of trials, the randomized controlled trials in coronary disease. In the middle of the slide are those with cerebrovascular disease, and on the right-hand side of the slide are the published RCTs for PAD. And if you look at those numbers, there's hundreds of thousands of patients in the CAD group, but hundreds of patients in the CLI group. And if this is Alec and Matt's slide where they weight it by size, so you can see there really is just a dot of evidence that exists in what is probably our most expensive treatment in cardiovascular disease overall. We looked at variation in the way that treatment occurs. Amputation rates vary widely across the country, as shown in some of the evidence we published in the Dartmouth Atlas. And then similarly, variation in the use of revascularization techniques is also dramatic across the United States. Darker areas are more aggressive, lighter areas less aggressive. And you can see there's 3 to 4-fold variation in terms of the way patients with critical limb ischemia are treated. In our National Registry of the Vascular Quality Initiative, we look to see at the center level how CLI was treated. Centers on the left-hand side of the slide use only endovascular interventions. Centers on the right-hand side of the slide use only bypass surgery, and everywhere in the middle occurs. So you could not find better equipoise. And I think this is why Alec and Matt and Kenny were lucky enough to receive, $27 million or whatever the total is at this point from NHLBI to perform BEST-CLI, which is an NIH-funded, prospective, randomized, multi-center, multi-specialty, pragmatic trial that's going to enroll 2,100 patients at about 160 sites. There are 2 cohorts, patients with adequate single-segment greater saphenous vein, that's cohort 1, and that's going to enroll about 1,600 patients. Patients are pragmatically assigned to either open surgery or endovascular treatment. There's a second arm. These are essentially patients without really good vein, and they similarly are randomized to either open surgery or endovascular treatment. This is important because it'll provide level 1 data for the treatment of CLI. It's well-powered, well-designed. It's pragmatic. What I tell my patients when I'm going to enroll someone is, look, the computer's going to tell us which step we'll try first. If that doesn't work, we'll just do the second one. You don't have to say, well, I'm going to use this kind of angioplasty balloon, or I'm going to sew the distal to this place because that's what the trial says. The trial is pragmatic. You can treat the patient however you think is best, whether it's open or endovascular, determining by which side you get randomized to. The outcome of interest is major adverse limb event-free survival or male-free survival. A major adverse limb event is an above-ankle amputation or a major reintervention like a new bypass, a jump graft, or an endovascular intervention such as thrombectomy or lysis. There's a variety of secondary endpoints that are shown here. Freedom from critical limb ischemia and the number of reinterventions are likely going to be some of the interesting data that I think we'll derive from this study. There's a cost-effectiveness analysis that will assess the cost of treatment along many points in the CLI treatment cycle. There's about 140 sites that are being used across the country, and actually several sites have been added in Finland, Italy, and New Zealand to make sure that really global interests are represented in this trial. The trial has been enrolling since 2014, and at present about 1,700 patients are enrolled. I think they've actually gotten a few in the last month or so since this slide was made, approaching 85% completion. As I said, I've been a big fan of this. Dartmouth Hitchcock Medical Center, where I practice, we're the 4th leading enroller in the country, and we just enrolled our 40th patient yesterday. And that brings me to the second part of my talk, which is what have we learned from the trial already? Well, the first thing I think we learned from looking at the patients who've been treated in the trial already is that the practitioners who treat them closely mirror those practitioners who take care of critical limb ischemia across the country. This is each bar here represents the specialty of the treating physicians, both in Medicare claims, that's the yellow bars, as well as the BEST-CLI trial, which are the purple bars. So you can see it's about an equal share of vascular surgeons, interventional cardiologists, and interventional radiologists across the country, both in terms of who gets their treatments in Medicare and who gets their treatments in the study. There's 930 investigators overall, which is spread widely across vascular surgeons, interventional cardiologists, radiologists, vascular medicine specialists, and even several others. So I think the argument that BEST-CLI is multidisciplinary and will represent CLI practice, I think is likely a good argument. Second thing I think we've learned from this study actually came, thus far, came from a couple patients I've enrolled, and I'm going to present their cases here. The first is an 85-year-old gentleman. He had 4-foot CLI. His son was actually a nurse that helped work in our cardiac care unit. He had a bad ulcer. He had non-compressible toe pressures, non-compressible ABIs and a toe pressure of 15. And he had this fairly severe distal SFA lesion. When I did his angiogram, I said, okay, well, we're going to put you in the trial, and I really hope you get enrolled to open surgery. This will be sort of a chip shot. We can kind of come from the mid-SFA and so to his pretty good baloney target at the bottom. But of course, he got randomized to endo, and I had to, wiggle my way through that, pretty complex behind-the-knee, popliteal occlusion. But it turned out it actually worked out all right, and this guy was actually fairly fragile, so he went home probably a lot quicker than he would have if I had done open surgery on him. So even though I didn't want to do endovascular treatment on this gentleman, I did, and actually worked out okay. Same thing happened here, but in the other direction. This is a 56-year-old gentleman who had long-standing diabetes, right foot tissue loss. He had had an old bypass, but had a runoff problem below it, as shown on this slide here. You can see the TP trunk has a lesion in it. Now, if I had not enrolled this patient in BEST, I would have just angioplasty that, that TP trunk lesion. I would have been done in 10 minutes and gone on to the next case. But I enrolled him, and of course he got randomized to open surgery. And the last time I came across the interosseous membrane and did a pedal bypass was more than a few years ago. But gosh, this guy had a good target for that, and he actually had some vein left. And so I told the fellow, well, go read about doing pedal bypasses and tell me how we get across the interosseous membrane. And we did a nice bypass that worked beautifully for this gentleman. So really in both patients, the initial treatment wasn't what I wanted to do. But I did it, and actually worked out pretty well anyway. So really, I think this trial has shown us that, if you live in the silos that were described earlier, you probably should challenge those biases because they're probably not correct. So in summary, I think BEST is going to likely provide us level 1 data that will help us to shape a much-needed evidence-based approach to CLI, and it's going to involve multiple specialties. It's a large multi-center trial, and I think evidence has shown that this will finish and can be accomplished. And our own biases and dogma are not likely to always hold true. So thank you very much.